Hello, everyone. My name is Mohammed Hagahmed. Thank you for joining my talk. And as I share with you my perspective on trauma care, I hope that you can rethink the ways you deliver trauma care to your patients in your healthcare systems, whether that be a level 1 trauma center, a rural hospital, or even a pre-hospital system. So again, my name is Mohammed Hagahmed, and I have no financial disclosure. You know, like one of the things that comes to my mind whenever I hear that sick trauma call coming to our hospital is that first, let me do what's best for that patient. But a few things that come through my mind. First, I don't want to kill them. And I'm sure you all share the same goal. And I also don't want to make their injuries worse. And one of the other things that I start to appreciate more and more as I keep doing this is that I want to prevent my patients from going through symptoms of PTSD. And one of the scariest studies that I read that showed that more than 20% of our patients that you and I care for after a traumatic injury, when they leave the hospital, within 12-month period, they start to experience symptoms of PTSD. And this is really a scary thing. I mean, now I'm more cognizant of taking care of, addressing pain or sedating them or stopping doing the stupid things that we do, like, cutting off clothes or, not feeding them or not keeping them warm. So ideally, in your trauma bay or resus bay, or wherever you work, you want it to be looking like this, right? Calm. Everybody's being pre-oxygenated. Your patients have been NPO for like 20 hours. That doesn't happen, right? In reality, your patients most likely look like this. They come in extremis. They're in distress. You might be the only one that is getting report from EMS. So you have to move in quickly. And sometimes things can be disorganized. When we talk about trauma, the initial, we talk about all these alphabet soups, but the one that you and I, were taught and trained in residency and fellowship is that think about the ABCs. It's all about the ABCs. But this is the first pitfall that I want you to be mindful of. A is not always first. So, the other important things that you have to address immediately, making sure that your patients are not hemorrhaging to death, right? Addressing severe acidosis, putting the needle in that chest to address tamponade or tension pneumothorax. So, we don't have to train our brain to jump automatically to airway. And this has been studied in the military setting where they looked at patients who were giving blood within the peri-intubation phase, and they looked at the incidence of hypotension. So patients who were given blood and who were actively hemorrhaging, obviously, were less likely to get hypotensive, defined as a systolic blood pressure of 70, than patients who were not given blood before intubation. So again, airway might not be the first thing you have to address. So addressing airway, I know we do things spontaneously all at the same time, but what is our goal? Our goal is to avoid hypoxia. Our goal is to ensure that these patients are optimally pre-oxygenated. And of course, we need to flush them out, right? So what are some of the tools that you have available to you that you can address those things? Of course, non-breather, nasal cannula, even BiPAP, BVM. So what I normally like to do for every trauma patient that comes in through the ED, I immediately put them on a nasal cannula oxygen, right? If they're hypoxic, I crank that sucker up all the way to 15. And also on top of the nasal cannula oxygen, I add in a non-breather mask as well. Now, what if you have to jump to intubation? I mean, this is something that you're not able to avoid. So we have the usual suspects, right? I'm sure all of you are familiar with these medications that we use regularly in your department for intubation and induction. So this is the other pitfall that I want you to be mindful of, that whatever you use for induction, in a trauma setting, or even in medical patients, each one of them or all of them has the potential of causing hypotension. Okay? Even ketamine, that we all like and, enjoy using, but be mindful of that, because these trauma patients have so many comorbidities that already predispose them to hypotension. I personally prefer ketamine still. And the reason why I love it, beside it being hemodynamically stable, is that I use it mostly for analgesia. Okay, I like the amnestic effect of ketamine on my patients, and I also use it for sedation. Sedating patients for procedures. Shoulder reduction, pelvic reduction, putting a chest tube, those kind of things. And the data support using ketamine, right? There's no difference between using ketamine and etomidate in the trauma setting, right? No difference in mortality, in the volume of blood they're getting, in ICU stays, and even mortality after discharge, right? Now, I'm not going to go over the debate of which one is better, Rocuronium versus Succinylcholine, but the true answer is it doesn't matter, right? So there is no association between paralytic choice and first pass success, whether you use Succinylcholine or Roc. Just use what you are comfortable with. Now, I'm going to bias you, is that my preference is Rocuronium. Why? Because of all these beautiful properties, right? I like it because it has, minimal contraindications. The risk of causing increase in ICP or intraocular pressure is less in Roc. And of course, there's longer safe apnea time, and that's what you need to facilitate with intubation and making sure that your patients actually do better during the process of intubation. Similar speed at higher doses. In my residency, in the trauma setting, we were trained to use DL first. And I know, I remember one of my attendings used to tell me that the reason why we use DL first in trauma, because if you use VL and that airway is contaminated, there is no way you'll get that optimal view. You basically effed yourself, right? But I disagree now. Now I'm more of an adopter of VL, and the reason why is this: because I can always lead with suctioning. I'm in a safe zone. So even if the airway is contaminated, I can suction and use a salad technique to clear that airway, to clear those debris. And even while I'm inside, I still leave the suctioning catheter on my corner, like on the left side, as I proceed with intubation. I tell you, sometimes I don't use a bougie. I tend just to use a stylet, and I have no problems with that. But even in a contaminated airway, salad is my go-to procedure to clear the airway before intubation. Last but not least, I want you all to be at peace with the scalpel. I don't want you to use scalpel when you think this is your last, resource. I want you to be comfortable with scalpel, because if you think that criking someone is your definition of failure, then I want you to change that mindset. And I want you to practice now and keep practicing to become comfortable with cricothyrotomy, because when that time comes and all of the airway adjunct or the intubation failed, you know what to do, and your patient will end up living through the process. So last, I want you to go home and leave you with these last summary points. So rethink ABC. Sometimes the airway might not be the first thing you have to address in a trauma patient. Of course, prevent hypoxia. Be prepared for induction and intubation, and use your medications wisely. I prefer ketamine and Roc for my choices, and don't be afraid to crack your trauma patients. And I hope you enjoyed this conversation, and hopefully you got a few points out of it. And I'm more than happy to get your questions via email, or you can feel free to reach out to me on social media as well. So nice talking to you, and thank you so much. Enjoy the rest of the conference.